All right, so orientation test for testing mental status. One thing I want you to not do is ask the patient the date. Because you know how many times I've asked people what today's date is today? Anybody know the date? December 4th, yeah. But I've had to ask people 2 or 3 times today. But that doesn't mean I have an altered mental status. Yeah, I'm just getting old. But we need to try to evaluate the person's ability to know the person, place, time, and event. Who they are, where they're at, the time, and the event that surrounds it. So you can ask them who they are, where they're at, and you can ask them the date. What is today? What is the day? Most people know what the day is pretty easily, right? Today's Wednesday, right?
Yeah.
No, I mean Tuesday, right? Or the month or whatever, and then the event surrounding what was going on, okay? So this evaluates their immediate memory, their long-term memory, and kind of gives you an idea of what's going on. And then we're going to go over this thing, and it's in your book, called the Glasgow Coma Scale, GCS. It can be very helpful. And it evaluates, based on an assumption, certain levels of things that can give surgeons predictors of a patient's outcome. Typically in the field we do this after the call's over and we put it in our reports. Rarely have we, if I see it, done too often. Only thing is GCS of 15 is normal and alert, what you are now. A GCS of 3 is that desk. 3 is the lowest you can get. So a rock has a GCS of 3. Now in a critical patient, sometimes we will sit down and figure out the GCS, because sometimes if they're less than a number like 8, we'll do what's called intubate. And this is our score here. GCS evaluates eye-opening, verbal response, and motor response. The way I kind of remember it is 4, 5, and 6. So starting with eye-opening, you can get a score 4. Verbal, you can get a score 5 as the top, and motor is a score 6. So here, a score 15 indicates no neurological disabilities, 13 or 14 indicates mild dysfunction, 9 through 12 indicates moderate dysfunction, and a score 8 or less is indicative of severe dysfunction. If you have an 8, that's a pretty sick patient. So we want to assess the airway. Now that we've got the level of consciousness. Now this whole thing, I've taken about 10 minutes to talk about assessing the patient's consciousness. In reality, it takes 2 seconds for you to do this, okay? Airway takes just a few seconds as well. Now we learned in CPR how to open the airway, right? Head tilt, chin lift, or jaw thrust. And we learned in the airway, jaw thrust or head tilt, chin lift, right? Alright, so that's what we're going to use here. We're going to open the airway. We want to look for signs of airway obstruction. If the airway is obstructed, we're going to clear it. And we're going to open the airway and make sure it's patent and adequate so that the patient can get plenty of air in and out. If it's a responsive patient that's talking to you, don't walk up to them and grab their jaw and open it if they're able to talk to you. That's why you check level of consciousness first. That's kind of odd, okay? Today I was doing some assessments, and we're doing trauma, and you're going to learn how to hold C-spine with your knees. So that means you got to put the patient's head between your knees. And I'm like, look, dude, and they just walked up, and that's the first thing they did. And I was like, dude, you know, you might want to make sure they're out of unconscious first, you know, because that's kind of odd, you know. You're just laying there, somebody just comes up and puts your head between the knees. That'd be kind of awkward situation, wouldn't it? So you want to make sure first. So this is a responsive patient. We don't have to go up and physically open their airway if they can open it themselves. Let them do it, because they can do a much better job. Watch and listen to how the patient speaks, because the patient's speaking like I am right now. What would you think about my airway?
It's open.
It's open, it's patent. But if I'm only able to speak 2 words at a time, would you think differently? Yeah. If you identify an airway problem, stop the assessment and obtain a patent airway. In the unresponsive patient, immediately assess the airway. Use the modified jaw thrust technique when necessary, or the head tilt chin lift when necessary. And know that a lot of times the reason why that there is an airway obstruction is because the tongue has relaxed and fallen back in the back of the pharynx. And that can cause an airway obstruction. And you just opening it by just doing a head tilt chin lift or jaw thrust may relieve that. So if that's the case, your next step would be to insert a oral pharyngeal airway or nasal pharyngeal airway. Very good. So signs of an obstruction in an unresponsive patient: obvious blood or other particles like teeth or tissue or something in the airway, right? Noisy breathing. If they've got bubbles coming out of their mouth, well then that's not good, right? Could be vomit or other fluids that need to be suctioned and cleared. Or extremely shallow or absent breathing.
What's crowing?
Crowing.
Crow.
Sounds like a crow. Oh! Don't make that noise. Same thing like a seal bark. Whenever children have like croup and everything's swelling, they'll sound like a seal.
Talking patients have an open airway. Quickly evaluate airway patency to ensure the airway remains open throughout patient care. In the unresponsive patient, first determine the possibility of cervical injury before opening the airway. If a cervical injury is suspected, open the airway using the jaw thrust maneuver. Consider inserting an oropharyngeal or nasopharyngeal airway if indicated. Quickly inspect the neck for injuries that could interfere with ventilation.
Okay, so now that we've got the airway taken care of, we want to assess breathing. Now, one thing I want to go ahead and point out here is whenever we assess breathing, we're going to do also, not only are we going to just scan, but we need to do a physical assessment quickly of anything that could impede breathing. And I'll get into that in a little further detail here shortly. So make sure the patient's breathing is present and adequate. Now, I've got a rule for every one of you to write down. It's one of Tom's rules to live by. If you have a patient who has an altered mental status and presents with any deviation in normal breathing, that patient requires positive pressure ventilation, PPV.
Say that again. Patient has altered mental status.
If a patient has altered mental status and any alteration in normal breathing, the patient will require PPV, positive pressure ventilation. Let's look at that for a second. One sign of hypoxia is altered mental status. So, if you have a patient who has altered mental status and they have an issue with breathing, what should you assume is causing the altered mental status? Inadequate breathing. So you need to ensure adequate breathing. And how do you do that? Positive pressure ventilation. You're 100% sure they're breathing now, right? So as we're assessing breathing, we want to obtain the following information: the respiratory rate, the rhythm, is it regular or irregular, and the quality or character of breathing, and the depth of breathing. Ask yourself, does the patient appear to be choking? Is the respiratory rate too fast or too slow? Are the patient's respiration shallow or deep? Is the patient cyanotic? Do I hear abnormal sounds when listening to the lungs? And is the patient moving air into and out of both sides of their lungs? And we're going to figure that out by listening, aren't we? So administer supplemental oxygen if the respirations are too fast, if it's more than 20, respirations are too shallow, or respirations are too slow, fewer than 12. So I need supplemental oxygen. Pretty much all patients are going to get some form of oxygen. Alright, so consider positive pressure ventilations with an airway adjunct wind, respirations exceed 24, or respirations are fewer than 8. Consider, it doesn't mean you have to, it says consider because you know what? When I walk up 12 flights of stairs, my breathing's probably more than 24. Doesn't mean I need PPV, right? But if I've been sitting on the sofa for the last 8 hours eating Cheetos, and now all of a sudden I can't catch my breath and I'm breathing 28 times a minute, I might need PPV, depending on what's going on. A normal rate in an adult ranges from 12 to 20, but let me tell you, normal and adequate are not the same. Can you have adequate respirations and breathing 8 times a minute? Yes, you can. Can you have adequate respirations breathing 26 times a minute? Yes, you can. It's all depending on the situation, though. So you've got to look at the situation and be able to tell, is it adequate or inadequate? And the way you can tell if it's adequate or inadequate, your number one indicator is mental status. Alright, if the patient has altered mental status, that's why I told you, if you have altered mental status and an alteration in breathing, PPV. Because the first thing that's going to suffer is going to be what? Your brain. The brain does not do well without a constant supply of oxygen and blood. So how are we going to count? We learned how to do this for vital signs, right? Count 30 multiplied by 2. Alright, so adults, here's the normal ranges, 12 to 20, children 15 to 30, infants 25 to 50. So quality of breathing. We want to listen to breath sounds. Alright, breath sounds should sound like just air coming in and out. We shouldn't hear really any noises in there. Just hear a wisp of air coming in and out. But if we hear like musical noises, like wheezes, something like that, then we've got some issues.
Assess the patient's chest for injuries that may compromise ventilation, such as tension pneumothorax, flail chest, or sucking chest wound.
Okay, so what are those?